We are back. This is Module 3, Lecture 3. We ended Module 3, Lecture 2 with the beginning of talking about the management of pain and discomfort, and we talked a little bit about some of the numbers relating to the importance of pain, millions of people in pain, patient-provider perceptions about pain, talked a little bit about the Institute of Medicine's report on relieving pain, some of their recommendations. Lots of people with back pain, arthritis, headaches, all relates to pain. And we stopped, and we'll start here with Lecture 3 on the meaning of pain and how the context is very important. And one of the first kind of discoveries that kind of led people to understand, at least initially, that pain is much more than just a physical experience was Dr. Beecher, Howard Beecher, who was a physician in World War II. And the quick story on that, and you can go to the reading to read the whole story, but basically where he observed many wartime injuries, when he treated the soldiers, he noticed a curious fact. About 1/4 of them requested morphine for what were often severe and very likely painful wounds, life-threatening wounds. When Beecher returned to his Boston practice, right on U.S. soil, he often treated patients with similar kinds of injuries through surgery, and found that about 80% of the patients, the civilians, appeared to be in substantial pain and demanded painkillers, whereas the soldiers did not. And the reason was, of course, because the soldiers realized, although pain wasn't enjoyable, they realized they were going home. And so their perception of the experience was different, the pain was less, whereas regular people who were getting surgery may not be happy with their lives and they wanted painkillers. They were in a lot of pain, although the injury experiences were about the same. So you get this idea that it's really important to understand that pain is going to be different for everybody, and it's going to be different depending on the context in which people are in. So pain is a biopsychosocial experience. The context matters. You may have experienced this in sport. Psychological distress can increase pain experiences, so people who are depressed have more pain. And then there's the pain of cancer versus the pain of labor, which is a very interesting phenomenon. And let's go right to that. In terms of an interesting article, here's the graph that you need to understand. So the figure right here is, on the left is cancer pain, on the right is labor pain. The white is sensory pain, and the gray is the unpleasantness of the pain. You can see how with people who have cancer that the unpleasantness is always greater than the sensory pain, which means the pain is worse. Whereas with women who are in labor, especially in the push phase, the unpleasantness is much less than the sensory pain. So you get the idea in these in these figures that the unpleasantness of cancer pain was enhanced by meanings that extend beyond that provided by the sensory qualities, including thoughts and images about tumor location, future implications. So, of course, people with cancer, it's a very serious thing, right? So if they're focused on the negative aspects, their unpleasantness is going to be greater. Whereas with women who focus on the positives, perhaps in the push phase, are focusing on the positives, and the unpleasantness is less. So the main thing to understand about pain is if you have an approach goal or a positive goal, because unpleasantness is going to be less. If you have more of an avoidance goal, the unpleasantness is going to be more. So again, another example of this context of pain being very important. So pain varies based on goals and experience, an approach goal versus an avoidant goal. So you need to understand where your patients and clients are coming from as far as their lives, because the pain is going to be distinctly and directly related to that context. So how do we experience pain? Well, negative emotions seem to make pain worse. So there is something to this idea of being positive, right, about your injury, about your future, because the negative emotions seem to make pain worse. Pain is a protective mechanism. So in some ways, pain is good because it's protecting in some way something, right, to make us aware that something is wrong. And again, the process of pain, I'm not going to sit here and say that I know exactly how this pain experience works. The reading does go into it in a little bit of a detail. The first sense of injury, your nerves send messages via the spinal cord to the brain. We'll show a picture of the brain in a minute, which then identifies the site of injury and send the messages back down the spinal cord, which leads to muscular contractions that can block pain and changes in other bodily functions such as breathing. And there are different kinds of pain perception as well. You have these things called nociceptive pain, which is more mechanical, and you have what's called neuropathic pain. And just to give you another example, I get a newsletter, right? I get a newsletter called The Moisture Seekers because of I'm a member of the Sjogren's Syndrome Foundation. And you can see here on the left-hand side of the newsletter, nociceptive pain, classified as pain stemming from known or proposed tissue destruction. Underlying tissue can be a bone, a tendon, or a joint, right? So Sjogren's, one thing that happens sometimes with people who have Sjogren's is they could have osteoarthritis or inflammation of the joints, right? Those could be treated with non-steroidal anti-inflammatory, right? But then you have neuropathic pain, which I haven't, fortunately, knock on wood, haven't experienced much. But neuropathic pain occurs because of dysfunction of the nerves. The nerves become actually inflamed. Such nerves may be functionally abnormal because they short circuit or because they fire irregularly and spontaneously. So you got to be a little bit understanding that there's different types of pain. Nociceptive is more mechanical, neuropathic is more nerve related, and the treatment might be different. Working with people with pain, it is complicated, but you have to go back to the philosophy of this course, which is every individual has kind of a biopsychosocial experience about illness or about pain, and you got to go with it. So there's psychogenic or psychosomatic pain. So pain can be psychologically induced. Depression increases perceptions of pain. So again, this connection with mind-body, very closely connected. There's acute pain or chronic pain as well. 6 months typically the guide. After 6 months, something's usually chronic. I'm not going to spend much time on this quote, but Bill Walton, who was a famous NBA basketball player back in the day, he's long since retired, but he talked about he was in so much pain because of his injuries, he wanted to die. And there's others. He's not the only one. So again, you're working with people who could be in bad situations with their pain. Sometimes surgery helps, sometimes surgery doesn't. So you got to be ready for all different levels and experiences of pain. And how do you manage pain? Well, bio-psycho-socially, right? So certainly pharmacologically. Now, there's lots of controversy over this, but morphine, painkillers, opiates, for example, Percocet, antidepressants, so on and so forth. The problem with these is that they are abused, and the dramatic increase in usage in these types of opiates has increased dramatically. For example, in 10 years, Vicodin, the most prescribed drug in the U.S. So again, you're certainly going to run into the pharmacological side, but then there's also other ways to treat pain through biofeedback, meditation, hypnosis, acupuncture, massage, many different kinds of ways to handle pain. And just to show you that there is a very interesting kind of development in pain. Again, picture of the brain. You can see all different aspects of these different aspects of the brain and how they're involved with pain. For example, the prefrontal cortex right here processes pain signals, active when trying to consciously reduce pain. But what they're starting to do right now, which is amazing to me, is they're starting to get people to be able to see their brain through these functional MRIs, right? Magnetic resonance images, but they actually show the person's brain and then they take them through meditation or some other kind of cognitive behavioral therapy and look at the percentages in terms of decreases in experiences of pain. When people can actually see the part of the brain that might be involved, they then do meditation and they find some very significant effects. So there's some fascinating kind of neuroscience-oriented work being done on how the mind processes pain and how you can use kind of functional stress reduction through meditation and so forth or distraction even, and how that dramatically reduces experiences of pain. So very exciting times in pain research and pain treatment, going beyond hopefully pharmacological experiences. So I've got about 4 minutes left, and with that, what I'd really like to focus on is a little bit more on the placebo effect. And we have a local guy, Dr. Ross, who's a friend of mine who works through McCullough Hyde, who has a pain management clinic. And if you're interested in that, you can let me know. And he's had people shadow him and so forth. But he also talks about pain as being a biopsychosocial experience. The placebo effect, there's lots of stuff that I have in resources under Module 3, under pain in terms of videos. Very interesting stuff going on. But you need to at least understand the basis of the placebo. So here's my quick attempt to help you with that. Again, some of this is in the reading. Placebo, any medical procedure that produces an effect in a patient because of its therapeutic intent and not its specific nature. Many of you have heard of the sugar pill, right, in terms of being used as a placebo. Placebo comes from I shall please. So here's the effect, the placebo effect, is that just the mere anticipation of improvement is the cause of that improvement and not the pill that you're getting. This works. Not in all cases, obviously, but it does work. About 30% of all conditions it seems to have some kind of positive effect on. Antidepressants has been an area of research. You'll actually have a learning activity which gets into that. Antidepressants don't seem to work any better than placebo for mild to moderate depression. Some very fascinating studies. You could go into the research and find these. I've found a few of them. For example, Parkinson's disease patients underwent a surgical procedure that transplanted human neurons into their brains. Half the patients, though, were told by their doctor, were merely told by the doctor that the neurons had been transplanted, so they weren't, and half said they were. The result, even those patients who received the sham operation showed significant improvement. Now, there's a lot of very touchy issues here, and you'll get into this with some of the work on the placebo effect and learning activities, but there's ethical issues, there's moral issues, but the placebo effect is real. But the American Medical Association, the AMA, even has a code of medical ethics to control this, that doctors actually have to tell their patients that they're giving them the placebo effect, and it still works to a certain extent. And doctors even get around that by, they don't even tell their patients. Now, I'm not advocating this, I'm just saying surveys show that doctors aren't perfect people. They're dealing with lots of people with lots of issues. So the placebo is real. It's something you need to be aware of. What we do in wellness, for example, is we just take advantage of the placebo effect, right? We're positive with people. We encourage them that they will get better. Not that we lie to them, but we do have this kind of positive approach, right? At least we should. And what they're finding in the research is that the importance of a warm, sympathetic relationship between the healthcare professional and the patient, as well as fostering a positive beliefs in both, should be encouraged. In other words, we don't have to trick people into being healthy. What we do is we know that this placebo effect or the expectancy effect works in a variety of situations. So why wouldn't we be positive? Again, not that we give people false hope, right? Or that we cross the line in any ethical way, but there are ways that you can function as a health professional to optimize the chances that your client or patient is going to get better. And this is a dramatic change from many years ago, 50, 60 years ago, when physicians were being trained. They were told not to really get into the lives of their patients, be very objective. That is changing, and you'll see a movie that kind of leads us into Module 4. You'll see the Patch Adams movie, which is Robin Williams, gets into this idea of what a physician should be about. So I'm on the home stretch here. We talked about pain. We talked about nociceptive and neuropathic pain. We talked about who gets pain. We talked about pain as a biopsychosocial experience. And most importantly, we talked about pain in the context of that experience. Soldiers versus civilians, and cancer patients versus mothers who were having babies. So a lot of interesting stuff. And we even got into the brain, right, in terms of some of the neuroscience relating to the brain. So on to Module 4.